Hi everyone, today we are going to be covering Chapter 15 in your book, General Anesthesia. The first thing we're going to do is talk about general anesthesia and airway management. So we'll define some terms, go over some different things with anesthesia equipment, talk about inducing general anesthesia, and explain some options for airway management. The first thing we're going to do is cover terminology. So the first term you'll see here is anesthesia, which literally means without sensation. But in the context of general anesthesia, it indicates a drug-induced temporary loss of consciousness. An emulsion is a mixture of two liquids that are not mutually soluble, and opioid is used to refer to any synthetic narcotic that's not derived from opium. The term has also evolved over time to include any agent, natural or synthetic, that produces the effects of morphine. Endotracheal tube, or ET tube, is an airway catheter that's inserted into the trachea to keep the upper airway open and provide ventilation. Intubation is insertion of that ET tube, and extubation is the process of removing the previously inserted ET tube. The pre-induction phase begins in the preoperative area, but this will conclude in the operating room as agents are administered to induce general anesthesia. The induction phase is an important time to pay attention to the patient in the regards to setting up for the procedure because they are extra sensitive to noise and movement. And this phase ends at the securing of the airway or intubation. And we will talk about these in more detail coming up, but these are just some definitions. Maintenance phase. This begins as the patient's airway is established and secured and then continues until the surgery is done. The emergence phase is the phase of general anesthetic when the agents are discontinued and allowed to wear off, and the patient will gradually awaken. Then this will end when the patient is transported to the PACU or post-anesthesia care unit. Also keep in mind the emergence phase is an important time to keep close attention to the patient. You want to kind of keep your noise to a minimum because, again, they're going to be sensitive to sound and movement during this time as well. Fasciculations, these are small muscle twitches noted when a depolarizing muscle relaxant is administered. Lacrimation is the production of tears. RSI stands for rapid sequence induction. This is going to be used for patients who are at a greater risk of gastric reflux and aspiration. Also, PACU, I mentioned this already, it's the post-anesthesia care unit. This is the location where patients will go after surgery to recover from their anesthesia. They'll be monitored closely, and then after this, they may either be discharged or go to a step-down unit like the floor med-surg, orthopedic floor, where they will continue to be taken care of. Laryngeal masked airway, this is also referred to as an LMA. This is an airway that's placed over the larynx. And then minimum alveolar concentration, and you'll see the term MAC used for this as well. Obviously, this is different when we talked about monitored anesthesia care in the last chapter, but in this context, we're talking about a measurement of the concentration of an inhaled anesthetic agent. So at 1 atmosphere of pressure, this will stop the motor response to incision of 50% of the patients. So that's related to general anesthesia specifically. So this slide just covers some basics of anesthesia, and it's basically the review of pain impulses. So in this instance, you have a pain impulse at the nerve endings. The sensory and motor nerves will carry that to the spinal cord, and then the brain will interpret those pain signals. And again, this is just exactly what I said in that previous slide, and you can see in this picture where number 1 is those nerve endings, so in this specific instance on the fingertips, and then it's going to travel through the nerves up to the spinal cord, which is labeled 2, and interpreted by the brain in picture 3. General anesthesia, so this is a systemic state of anesthesia. We're talking about the whole body here instead of that regional area of anesthesia we talked about in the last chapter, or a specific site anesthesia and local. So this interferes with the brain's ability to interpret pain impulses coming from anywhere in the body. It's going to be used when there's multiple operative sites or on a procedure that has an area that's difficult to block regionally. So again, I know I can't ask you guys specifically since you're not in class right now, but I'll give you examples. So what kind of procedures can you think of that would be difficult to block? We're talking like big abdominal procedures. If they're doing an open laparotomy, that's going to be difficult to block. Multiple locations of procedures. This would include skin grafts because they're going to be taking a skin graft from the thigh and placing it on whatever part of the body that needs that graft, forearm, belly, wherever. Breast reconstructions and autologous bone grafts. So you're taking bone from one part of the body and transplanting it to another part of the body. So those are the multiple area procedures. So there will be two factors that are going to drive the decision to administer general anesthesia. The first is the surgical procedure itself. And so again, it's going to be usually used for procedures that impact multiple sites, such as skin grafts, when procedures require a motionless field, such as those on the retina, or anytime the procedure is expected to take a long time. So those are procedure considerations. And then on the second end of this, the factor that drives the decision of general anesthesia is the patient themselves. So patient age, are they too young to hold still using a regional or local block? Cognitive ability, are they demented? Do they have Alzheimer's? Mental or emotional state, are they too stressed to hold still for a procedure? And then patient preference when possible. So if the patient's going to be really frightened by the idea of a spinal needle and is otherwise in good health, general anesthesia may be more appropriate for them than regional anesthesia. So there's going to be some different components to the anesthesia workstation. If we were in class, I would actually take you guys to the lab to show you the machine itself, but your book does have a good picture, and on the next slide I'll show you a picture as well. So these are going to include manual and automatic ventilation systems, which is hooked up to a breathing circuit that's going to provide oxygen to the patient and keep them breathing. Oxygen and nitrous oxide pipeline hoses and backup tanks. This is what will provide that air for the patient. Vaporizers, what can be used to vaporize anesthetic gases. There'll be pressure regulators and gas mixing components, and gas scavenging systems that kind of collects the excess gas from the machine when it's been breathed back. And keep in mind there are alarms set on the machine to emit a signal when readings occur outside of preset parameters. So if something goes awry, the machine will alert you to that. You can see here the picture of an anesthesia machine. Like I said, I wish we were in class. I could give you a better view. But there's just some different things here that I'll show you. So this over here that I'm circling with the yellow, that is a breathing circuit, and the bag there, that green bag that I'm drawing the X on, that you can see that inflate and deflate as the patient is getting ventilated. And then up top, monitors here, here's that biz monitor we talked about in the last chapter, another monitor. All of these will give the patient monitoring, so blood pressure, carbon dioxide, O2 sats, all of those things will be monitored continuously, and the anesthesiologist can look up here to see what is going on with the patient. You'll see a couple hookups here towards the middle. That is where your anesthetic gases will go in. You can refill them, and they're usually in a liquid form, and the machine itself vaporizes them to provide that to the patient. And then you can control level of gases with these knobs here on the left. Typically, there's also suction hooked up on the right. So if you need to suction out the patient's mouth before or after surgery, you can use that to suction it out. And then drawers here in the middle. These will keep different supplies, extra monitors, longer blood pressure cuffs for larger patients, different things like that that the anesthesiologist might need. General anesthesia is accomplished by administering agents to achieve the major goals that we're going to talk about here: unconsciousness, analgesia, amnesia, and immobility. We'll talk about these a little bit more in detail in these next couple slides. First of all, we'll talk about unconsciousness. This just means that the patient is unaware and they don't respond to any stimuli. Analgesia is meaning that the patient does not experience any pain, and amnesia is they will retain no memory of the event, no recall, and then they also will have no awareness under anesthesia. If I could talk, that would be helpful, wouldn't it, guys? And then also you want the patient to be immobile and stable throughout the surgery. This means that their muscles are relaxed. You might also hear the old term that the patient is paralyzed used. A lot of times during surgery, especially during abdominal surgery, we really need the patients relaxed well for a couple different reasons. If they aren't relaxed, it makes visualization a lot harder because everything just kind of pushes up and out and you don't have a clear view of anything. And then also when you're closing everything up, when you're done with the procedure and you start suturing, if they're not relaxed, it's really hard to get the fascial layers closed together and hard to pull them together. So a lot of times you'll also hear surgeons asking, is the patient relaxed? And anesthesia, typically says yeah, and then they may give them another dose of medication to ensure that they are fully relaxed. So there's some different ways that you can administer general anesthesia. These are the most common methods listed here: IV, inhalation, or then a combination of the two methods, which is called balanced anesthesia, are the common methods used. Less often, sometimes they will do a regional block, which we talked about in the last chapter, with a light general anesthetic agent. So this isn't used quite as often, but they might do this especially in high-risk patients. You might see it used then. So we mentioned already before in the terminology the different phases of general anesthesia. You can see them listed in the order here. They start with pre-induction and end with the recovery phase. So we'll talk about these in a little bit more detail. The intraoperative phases when surgery is actually being done or not, maybe surgery isn't being done, but more of the operative phase are induction, maintenance, and emergence. The first phase of general anesthesia is pre-induction. So this will begin as the patient is admitted to the preoperative holding area and continues to the point of being administered anesthetic agents. So this will include assessment of the patient, their preparation including clipping, extra cleansing of the skin. They'll be transported to the operating room. Pre-oxygenation, which you can see in this picture, is where they're going to hold that anesthetic mask over them and then just have them breathe some nice oxygen, and then administration of anesthetic agents. So this will include everything up until anesthetic agents are given. After pre-induction comes the induction phase. So this is one of the intraoperative phases. It begins when the medications are administered to start general anesthesia, and it will end when an adequate depth of anesthesia is reached and the patient's airway is secured. So there's a couple different ways to manage a patient's airway. You can do just a regular mask, which is placed over the patient's nose and mouth. They'll be given oxygen and inhalation agents, and this is used on very short procedures. So with this, no muscle relaxation is required. The short procedures we're talking about are myringotomy and tubes. So when you're talking about ear tubes, this a lot of times is done on pediatric patients with just this mask airway. You can see in this picture the anesthesiologist is up at the head of the bed and he's holding that mask over that patient's face, and they're just breathing those agents in, and then they'll do the procedure pretty quickly, and then they won't have to actually put any kind of tube in their mouth or throat. Another option for airway management are LMAs. So these are usually done for procedures that are pretty short, and they will actually put this in. You can see a picture here. These do come in a couple different sizes. We do have small ones for pediatric patients, but typically adults will get a size 3, 4, or 5. So the LMA doesn't require laryngoscopy or muscle relaxation, so it's going to be really useful for ambulatory surgical procedures. That means those outpatient procedures that are pretty short duration and the patients go home afterwards. These are ideal for that. It sits on top of the larynx and it'll administer oxygen and inhaled agents. But there are some really important contraindications for patients you don't want to use these on. If they are having an oral procedure, you don't want to use them because they'll block everything you're trying to see. Obese patients, hiatal hernia patients that have those already, patients that have GERD, or low pulmonary compliance. Basically, those are contraindicated with this just because it causes too high of a risk. And if you guys want, you can look up a video for LMA placement. They have some on YouTube. They're going to be good, and you can see exactly how that sits in the mouth on the larynx. An endotracheal tube is going to be the last option for an airway management. This is needed because a lot of patients are going to be inappropriate candidates for the masked or LMA airway and need more precise airway control. So this gives maximum control, is going to be used for longer procedures. It's used to administer gases and inhaled agents. Like I said, used for longer procedures, when deep muscle relaxation is necessary, and when a patient is in prone, which means they're laying on their belly during surgery, or lateral position, which is on the side. I mentioned on here the deep muscle relaxation. If you need that, you're going to have to use an ET tube because the agents that you're going to do or use for that relaxation, they will paralyze the diaphragm as well, so the patient won't be able to breathe on their own, so you'll have to have an ET tube in place to breathe for them. There are some variations for placing the ET tube. You can use what's called a rapid sequence induction. This is when the patient has food in their stomach because it's an emergency surgery, but it still needs to go very quickly, so maybe they ate a couple hours before surgery. If they have GERD or a hiatal hernia, you want to use that rapid sequence induction. They also can use this for an nasal intubation. Instead of going through the mouth, though, they will kind of place the tube through the nose and down to the trachea that way. This is when you're going to have to do procedures on the oral cavity. And then also awake intubations can be used in conjunction with this. So if they have the potential for significant problems with ventilation or intubation, they've had a difficult airway in the past, maybe they have an unstable cervical fracture, history of facial deformities, all of these kind of things can make for difficulties when intubating. So they might want to do it awake to ensure the best possible outcome for that patient. Next up, we'll talk about the phases of surgery and anesthesia medications. So this will be more related to what's going on, starting with intubation and that part forward. We'll also talk about induction agents, analgesics, inhalation agents, neuromuscular blocking agents. And we will talk about reversal agents as well. Endotracheal intubation, this is going to be when they'll use a short-acting muscle relaxant. They'll give that to the patient, wait for it to take effect, and then they'll insert the endotracheal tube. It is placed through the patient's mouth into the trachea, and then they're going to verify placement of the tube that it's correct. They might use this with auscultation of bilateral breath sounds with a stethoscope, and they also will look at measurement of exhaled carbon dioxide. You can see a picture here of a laryngoscope. That's going to be in the middle. This little cylinder type thing here. Nope, not that. There we go. That is the laryngoscope. It has like a little battery that goes in the inside, and then one of these, they're called blades, hook onto it. We have what's called Mack and Miller blades. The Miller blades are these ones on the left. They're just kind of a straight blade, and they come in different lengths or sizes. And then the MAC blades are on the right here. They have a soft curve to them, and those also come in different sizes. They'll pick out the size depending on anesthesiologist preference and the patient size. It is important that you guys are aware that during this time, the patient is going to be highly reactive to noise during this phase. So you need to be careful when you're setting up your instruments and try not to be super noisy. You don't want to just throw things around because it can be disturbing to the patient during this phase. So the next phase is maintenance. This begins as the patient's airway is set and secured and continues until the procedure ends. And then the anesthesiologist will give agents as needed, or PRN. We've mentioned a little bit about awareness under anesthesia. So this is disturbing phenomenon in which some people have direct recall or memory of what's going on during surgery. Patients that are at an increased risk of this are those that have a history of substance abuse or chronic pain issues. So this affects us directly in that we can't necessarily assume the patient's unaware during surgery and unaffected by our conversations and comments. So we want to make sure at all times to keep everything appropriate. So muscle relaxation, this is also critical to the maintenance phase. Often a long-acting muscle relaxant is given during this phase, and it's going to be important to time this appropriately. You really want to have this present throughout closure of those deep wound layers. When I talked about closing the fascia, and you want them relaxed because it's harder to pull together otherwise. And then you kind of want it to wear off as the superficial layers are closed. They can monitor this with a nerve stimulator, which we talked about in the last chapter. So if they want to see if it's wearing off, they can utilize that tool. And then emergence is the third and final intraoperative phase of general anesthesia. So remember, there's also the recovery phase after this, but as far as during the intraoperative phase, emergence is going to be the last one. So this will start when the surgical procedure ends. Agents are going to be discontinued or allowed to wear off, and then the patient will kind of gradually wake up on their own. They'll take out whatever airway they have in place, and then this phase ends when the patient is transported to PACU. Again, be alert during this phase. Patients are going to be highly reactive to noise again. So you want to be quiet and attentive when you're cleaning up. Try not to throw instruments around, bang things, and just kind of be aware and quiet. So extubation, this is the process of when the ET tube is removed. After this, a mask may be used to administer oxygen to the patient if necessary. And then the anesthesiologist will give a detailed report to the PACU staff nurses once they are taken over there. In order for them to go to PACU, the patient needs to be breathing on their own and able to maintain that airway independently without any assistance. At this point, the patient is going to be admitted to the PACU, and this is where the recovery phase starts. The patient is going to fully awaken, and then their vital signs will be monitored, and they have to be stable before being discharged. You can see here, if you want, like just a little bit of a summation of the different phases too, induction, maintenance, and recovery, and where the surgery kind of actually happens within those phases. If you look at this box 15.3, it's also in your book, but these are the major categories of anesthesia medications. So we'll talk about IV induction agents, analgesics, inhalation agents, neuromuscular blocking agents, and reversal agents. So first up, we are going to talk about intravenous induction agents. All of these different things contribute to a component of general anesthesia. The first three we'll talk about on this slide and the next two on the other. But the IV induction agents, these are what actually produce unconsciousness or put the patient to sleep if you're kind of talking in general terms. Analgesics, these prevent perception of pain, so they're unaware that they are being worked on, I guess you'd say, during surgery. And then the inhalation agents, these produce unconsciousness as well, and they prevent motor response to painful stimuli. The other categories are neuromuscular blocking agents. These are used for muscle relaxation for intubation and the procedure itself. And then reversal agents counteract the action of various agents. So IV induction agents. These are going to include a couple different things. These are used to induce unconsciousness, and they're classified as sedatives or hypnotics. Sedatives are going to include benzodiazepines like Valium, Versed, and Ativan. These are going to be used for induction. And then hypnotics, these are also used for induction, and these will include barbiturates, etomidate, propofol, ketamine, thiopentanol, all of those will be barbiturates. So just a couple different ways to basically induce anesthesia. It just depends on whether they want to use sedatives or hypnotics. It's going to be important that you guys know what propofol is. You'll see this pop up on the medication exam. There's probably, I can't remember if there's a test question on the final as well. But propofol is the most commonly used agent for induction. You can tell what it is by its milky white appearance shown in this picture. And be really careful. You do not want to give this to patients with allergies to soy or eggs because these substances are part of the emulsion. And this is an emulsion agent. So remember all of those things I just said about this one. So after sedatives and hypnotics, there's a second class of agents known as the analgesics. These are given during the maintenance phase to prevent pain, and these also fall into two categories. The most common analgesics are the opioids. These have morphine-like actions and include morphine and codeine. And then there's also synthetic opioids, fentanyl, alfentanil, sufentanil, remifentanil, all of those are synthetic ones. There is a table in your book 15.1 that's shown here. It's just a comparison of different opioids used for surgery, and it shows you generic and trade names, how long it takes for them to take effect, the onset, and then the duration, how long they'll last. So you can kind of compare different ones, and they may kind of tailor this to how long the procedure is. If they're having a longer procedure, they may decide to give fentanyl because it will last longer. The third class of general anesthesia agents are the inhalation agents. Volatile inhalation anesthetics, these are bottled and distributed in liquid form, which I kind of mentioned before. The liquid is then poured into a vaporizer on the anesthesia machine, and then the machine itself turns it into a gas that's breathed in by the patient. In clinical practice, especially dental procedures, nitrous oxide is the most widely used inhalation agent. And then in surgery specifically, you'll see isoflurane, desflurane, and sevoflurane. All of these are used quite frequently in surgery. Selection of the inhalation agent is influenced by factors like their solubility of the gas and the patient's cardiac output. Disadvantages for inhalation agents are the increased potential for cardiovascular depression and lack of postoperative analgesia. So afterwards, they're not going to have pain control if they're just given this agent. The fourth category we're going to talk about are the neuromuscular blocking agents. So when a patient goes under general anesthesia, they may be unconscious, they may not have any pain, may have no memory, but their skeletal muscles will respond to stimuli. So remember, a muscle to contract, it has to be stimulated by a motor nerve. And then remember, there's three types of muscle tissue: cardiac, smooth, skeletal. So we're going to give these neuromuscular blocking agents for intubation. We have to relax them to get that endotracheal tube in. And then also to do the surgery itself, we want to relax them. Anytime we do have a neuromuscular blocking agent, you'll see a warning label that's shown in this picture on it because it will cause their respirations to cease, so they're going to have to be ventilated somehow. Neuromuscular blockers are characterized as being depolarizing and non-depolarizing. So these relax skeletal muscles for intubation and surgery. So depolarizing means that they bind to a receptor site, initiate a contraction, and then they stay on that binding site. And then the non-polarizing, these act as acetylcholine antagonists, and these block and prevent acetylcholine from binding to the receptors. You don't have to remember this, I just wanted you to know what the difference was between the two. So basically the succinylcholine, this acts similarly to the neurotransmitter acetylcholine, but its duration is going to be longer. So the selection of particular non-depolarizing relaxants depends on its properties. So you might see, probably one of the main ones we see is rocuronium when they're using one of the non-depolarizing. And again, it depends on anesthesiologist and patient what they use. Table 15.3 is going to compare the duration of neuromuscular blocking agents. So you can see succinylcholine has a duration of 4 to 6 minutes. So ideally, this is going to be used a lot of times for intubation. They'll give that, and then they'll wait a little bit, and then they'll be able to put that breathing tube in, but then it wears off and it's fine because that tube's already in place, so it's not going to matter if they're not relaxed anymore. You can see the duration on these other ones is a lot longer. Rocuronium lasts up to 85 minutes, so that's why we typically see it a lot in the main OR for those longer procedures. And then the last thing we'll discuss are reversal agents. So these counteract specific anesthetic agents, and they're designed basically for surgeries that end sooner than expected. So they're going to give a reversal agent if they need to get rid of that initial anesthetic agent. For opioids, you'll probably heard of Narcan. That's one. And you can also see Revex and Trexan. Those will be some other ones. If you're needing to reverse benzodiazepines, they can use flumazenil. So it'll just be very specific as to what you're trying to reverse as to what drug you give here as an agent. If you want to reverse non-depolarizing muscle relaxants, you want them to start breathing on their own again, you can give neostigmine and indorphanum. You'll give neo a lot of times. So here's just a little summary table of different reversal agents. Again, it's in your book, and you can see exactly what reverses what. Okay, so last thing we're going to talk about here, advanced practices. Cryotherapy is going to be used in surgical specialties like dermatology and gynecology. It basically chills a part of the body or peripheral nerves to numb the area against pain. Hypoanalgesia was approved by the AMA in 1958. It's kind of an alternative form of medicine. It's been used by dentists, OBs, and midwives in place of local anesthesia for a long time. But it's basically going to be kind of unpredictable because it depends on the patient's willingness and acceptance of the method. And then acupuncture. This involves stimulation of anatomical points of the body by varying methods. It was developed in China more than 2,000 years ago. So it kind of looks at the theory of balance of flow of energy or life force that's believed to flow throughout the pathways of the body. So these are just a little bit more of alternative ways to manage pain. Okay, and that is it. Please let me know if you have any questions, and I will see you guys next lecture.